So for today, we have two very renowned faculty, Professor Yuping Wang and Professor Tao Yu from Beijing. And both of them work in very busy centers where they do a large volume of epilepsy surgeries. And we really look forward to having them share their experience with us and also give their inputs for the case today. Now, I would like to share a screen so as to do a few announcements before we proceed. So is my screen visible, Vineet? So today's is a session 9 of the series of epilepsy surgery case by case, step by step. And today we would be discussing epilepsy surgery related to the dorsolateral frontal lobe, including the Broca's area and how to manage them. My co-convener, Professor Kensuke Kawai, unfortunately could not join us immediately, but he said he will join in a few minutes later. And this particular series has been possible because of an unrestricted educational grant from IPCA, and we really acknowledge them. So I would like Professor Ikeda to say a few words before I introduce the faculty. On behalf of the AOILE.
Hello, good evening, good afternoon. Could you hear me? My name is Akio Ikeda, the past regional chair of ILE Asia Oceania. It is a great the honor to have the regular conference of epilepsy surgery case by case and step by step. It is now today's the 9th sessions. So in the past, we have extensively have the excellent the guest speaker and then the discussion of a case and learned a lot for the based on that the case discussion. And on this occasion, we are very pleased to have the guest from the region of ILE Asia and Oceania, which is the one of the largest the epilepsy center in the world, as well as the Asia and Oceania. That by the Professor Yupi Wang, who is my old friends. So we're looking forward very much to having that discussion today. So I will pass it to you over. Thank you.
Thank you very much, Professor Ikeda. And first, of course, we will have a case presentation by my colleague Manjari, who happens to be our epileptologist, has more than 30 years of experience as an epilepsy surgery unit center in our place, and she has more than 400 publications. And then, of course, I have the great pleasure of introducing Professor Yuping Wang, who is a professor of neurology and is a president of Hebei Hospital of Zhuanwu Hospital, Capital Medical University from Beijing, and he happens to be the director of Comprehensive Epilepsy Center at Beijing, board member of China Neurological Society, vice president of China Association Against Epilepsy, and chairman-elect for Chinese Psychosomatic Medicine Association. So welcome, Professor Yuping Wang, and once again, thank you for agreeing to be part of this webinar. Our next faculty is Professor Tao Yu, who is a professor of neurosurgery. He is a deputy director of the Department of Functional Neurosurgery from Zhuanwu Hospital, Capital Medical University, Beijing. And he also happens to be the Deputy Director of Beijing Institute of Functional Neurosurgery. So once again, a hearty welcome to you, Professor Yu, and thank you very much for joining us in this webinar. So now I will request Manjari to start presenting her case, and I will request the faculty to feel free and interrupt Manjari whenever they want, because this is an interactive case presentation. So whatever queries or whatever doubts or whatever comments you have, please do feel free to interrupt her in between, because that is the way we would have the audience learning most from this case discussion. So Manjari, please go ahead.
Thank you. I would like to thank Professor Ikeda, Dr. John Dunn, and Kensuke, as well as Dr. Sarath, as well as the invited esteemed faculty, Dr. Wang and Dr. Wu. We have case 9 today, and this is pertaining to a part of the frontal lobe. We know the frontal lobe occupies a large real estate in the brain. So this is a small fraction of that frontal lobe. And he's a young man. He's 22 years old. And he's brought in by his concerned parents who have been trying to get his seizures controlled for a long, long time. So the semiology or the symptoms which the parents, particularly the mother, relates to us is that the episodes are really, really very, very brief. They hardly last for a few seconds. And 9 out of 10 episodes actually occur in sleep. There have been very few episodes while awake, but there have been episodes when he is awake. He really does not give them any warning. He becomes still and he stiffens, and there is a movement of his upper limbs with some flaying of the hands, which they are unable to tell whether it is unilateral or bilateral. And they have also noticed some posturing of the upper limbs, but they're not very sure whether there is any dystonia. They just say there's stiffening and flaying of the upper limbs. As I said, this is very, very brief, and immediately after the event is over, he responds completely and normally. Most of the episodes get him out of sleep, and occasionally in his lifespan of 22 years, the age of onset of these episodes was when he was 5 years of age. So he's been having them for more than so many years, and say once or twice a year, these episodes are associated with generalization with movements of all 4 limbs and urinary incontinence, that too in sleep. His frequency, initially when it started out was 4 to 5 per month, but by the time he presented to us, he was having about 4 to 5 every night in sleep. So really, from this history, where the episodes were very, very brief and occurring in sleep, and rather consisted of just some tonic movement or maybe some abduction of the limbs, though not truly a complete abduction. The hypothesis based on this semiology was that he was probably having seizures of frontal lobe origin. The side we could not hypothesize from the history. However, since the patient was responding to commands immediately, we were thinking it could be a non-dominant frontal lobe because there was no post-ictal aphasia ever documented historically or otherwise. So there was a significant history in that the mother said that he attained his speech milestones late. He actually spoke monosyllables only at 18 months or so. And then he gained speech, but it was rather slow compared to his peers. There was never a history of any head injury or any febrile illness in the childhood or any encephalitis or meningitis. He had studied and he had done a correspondence course, and his parents had got him a job as a data entry operator, which he was carrying out from home itself. He used to work on various projects and people used to give them data to enter, and he was able to do that. He had been, restricted to his home, restricted to in front of his computer, and restricted within his own, environment of his room. And when he came to us, he had swollen lower extremities, which on investigation revealed a chronic deep venous thrombosis of both his lower limbs. So basically his epilepsy and inability to socialize had confined him to home, and probably he had restricted fluid intake and prolonged sitting time because of his activity as a data entry operator, and he had a comorbidity of bilateral lower limb deep venous thrombosis. He had, prior to coming to us, sustained a fall before coming to us. And this fall was following one of the seizures which occurred in the morning hours with generalization, and he had sustained a vertebral fracture at the lower thoracic lumbar region. However, there was no compression of the spinal cord. At the time of the fracture, again, he was confined to bed for some time, and that could be another reason why he had venous thrombosis of his lower limbs. He was on 3 anti-seizure medicines, and the reason the parents got him to us was that even though he was having seizures from 5 years of age, the fall and the fracture scared them, and the fact that after that he had been confined to bed and then developed venous thrombosis meant that many of the physicians who were looking after him before he came to us told them that these falls and fractures will happen again and again because he has refractory seizures and you better do something about it. So even though he had been having seizures from 5 years of age, he presented to us at the age of 22 years. On examination, there was a good naming, a good repetition. He had a good output, but he would take his time replying and he would be very slow with his replies. There were no other focal deficits, and there was absolutely no sensory or motor level except wrist reflexes, and there was a normal power in the lower limbs, and he was, walking around slowly with the DVT. His neuropsychological assessment showed a moderately impaired working memory in the verbal domain. However, he had intact visual working memory as well as recent memory, both verbal and visual, are intact. He had mildly impaired executive and attention frontal lobe functions. So from neuropsychology, what we could gather was that he did have some impaired frontal lobe functions. Otherwise, he was appropriate in most of his responses. With this hypothesis of frontal lobe seizures, we then tried to monitor him. And as predicted, so you can make out both his lower limbs are swollen and the right lower limb is a bit more swollen. So that was the one which had more venous thrombosis. And most of his episodes, which we documented, in fact, almost 99% of his episodes occurred out of sleep in the epilepsy monitoring unit. So one such episode in sleep is just abduction of the right upper limb, and that's it. That is how brief the episode is. And he gets up. He's being asked. He's immediately responsive. He's obeying commands. He's answering appropriately. There was no postictal aphasia. He's telling his name. He's telling his problem. He's identifying objects. He's naming objects. Telling the color of the object. It's a small car which we use for testing. So a very brief episode. Another episode. So we documented several, and since ictal spect is done in the morning hours, we make sure they are sleep deprived for the ictal spect so that they sleep. So the event was detected by the technician, and he's injecting the ictal spect tracer, and immediately he's responsive. So very, very brief event. The ictal spect has been injected. Responding very well, naming things. He can name his mother. So basically, these events were more or less, so again, abduction of the right, mild tonic abduction of the right upper limb, and then he recovers immediately. So based on this semiology, where we witnessed very, very brief events lasting for few seconds, maybe 10 to 15 seconds or even less than that, of a tonic, kind of mild abduction of the right upper limb with immediate responsiveness. Our hypothesis was again frontal lobe seizures, and since it was the right upper limb which was kind of moving away from the body, we kind of lateralized it to the dominant, he was a right-handed individual, so we lateralized it to the left frontal lobe. However, there was no postictal aphasia at all. There was absolutely no aphasia. He was naming things. He was recognizing objects which were shown to him. He was naming their color. He was, even obeying commands. So the motor output was good immediately following the seizure, as well as the comprehension component. So, and there was a primary motor response of some kind of tonic as well as abduction. So we thought it was, probably coming from the area 2, which is described by Bonini, the group 2, which we will discuss. It didn't have any clonic movements. It didn't have a fencing posture. So definitely the SMA was a little less likely. With this interpretation of semiology, I'd like to ask Dr. Ikeda and Dr. Wong how they would interpret his semiology and discuss that. Yeah.
Okay, could you hear me?
Yes, sir. We can hear you.
May I say?
Yes.
Okay. That's the very and interesting and then the very difficult cases. And then I have 2 questions. First of all, you mentioned that the once or 2 times a year, the patient have presumably generalized the shivering of the whole body with or without loss of consciousness. He is aware while the patient have the generalized shivering or the seizing. That is my first question. And then second question is that you showed nicely that the 2 video of the seizure. And when I see that the first seizure, patient shows that the moderate degree of the right hand, the abduction from the shoulder, but at the same time, slightly hits, and then presumably its eyes are turning to that the left-sided. So if it's that actually the turning to the left side of the eyes, whereas that the hand shows that the abduction of the right, so it is not the primary area of the frontal lobe or the primary motor cortices. So I just wondering that the eyes movement is always dissociative with that the right hand abduction, although the degree of the eyes and head movement is very slight. And then based on this, that's the 2 questions before the discussing.
Yeah. So when we asked him as well as his mother, who's a primary caregiver, if there was any aura before generalization, so he would say, "I just fall," and he's aware of the fall. So he would fall, and he was aware of the fall, but then following which, when he would have generalization as per the mother, that is, there would be tonic-clonic movement of all 4 limbs, during the last of which he fractured his vertebrae. He had no recollection. So there was definitely an altered sensorium which was associated. So he would remember he's falling, and then he would not remember anything beyond that when he had generalized. So that was the answer to that. And the falls seemed to be very sudden, so he couldn't really warn anybody or take protection or lie down. The second is the eyes, which you described very correctly. If you look carefully, just before his hand kind of moves outwards, there is a subtle movement of his head and his eyes. As you can see now, this is happening. And this was not seen consistently in all events. It was very brief. It was not seen consistently in all events. You would see it only in, I think we monitored, we had around 11 events on him over 2 nights, and he had them only in about 3 or so. So it wasn't a consistent finding. There was no forced head deviation, and there was no forced eye version. So we were not very certain as to how to interpret this finding. It definitely didn't look like a contralateral sign because it wasn't forced. Yeah, that is the answer to the second question, Dr. Ikeda.
Okay. Okay, thank you very much. Then I may have some discussion. The seizure is the quite stereotypy involving that the right shoulder abduction and then we added some mild degree of the head version to and the eye deviated to the left sided. So it is outside of the primary the motor area or the frontal eye field. The one candidate area, the supplementary motor proper. So the SMA proper may have a dissociated direction of the eye movement as well as the hands, the movement in the laterality. And then interestingly, as you say that the 1 or 2 times a year, the patient have the big fall without any generalized tonic-clonic seizure. So it may suggest us that the patient have some sort of big the falling with the stiffening, without the tonus of the muscle of the anti-gravity muscle. So which can be caused by that the propagation to that the pre-supplementary motor area. So we experience that some patient with the SMA proper seizure with that the asymmetric posturing and the involving that the rostral part of the head, rostral part of the body, namely eye, and then all of a sudden the patient falls as if that the atonic seizure. But this is actually involvement of the rostral to that this supplementary motor area proper, namely pre-SMA. So in order to explain that the whole finding in that some propagation in the mode, I just wondering that the patients start having a seizure, the rostral part of the supplementary motor area proper, then spread to that the rostral parts of this area, namely pre-SMA. So that could be the one possibility. So and speaking, that is the semiology. The one added comments for that the drug. The patient was on that the levetiracetam of 3,000 and the clobazam 45 milligram and the lacosamide 400 milligram. But I'm just wondering that the clobazam of the 45 milligram may be causing that the quite a high concentration of the clobazam, making some sort of the sleepy or the dizzy feeling, which may facilitate some falling. So that is my some additional comments. Thank you.
Dr. Wong?
Yeah, this is a very difficult case, I think. So, according to semiology, the first no aura, and the first symptom is the abduction of right arm, and then he slightly turn his head to the left. After that, sit up. So totally with even during the seizure, he could respond to the comments with the with no consciousness loss. So generally, the seizure lasted not too long, and the seizure is not so violent. This is a difficult case. So maybe the first, the initial symptom, the right arm abduction, is very important to localize to maybe the left side, left hemisphere, the premotor, some area around premotor, and the discharges may be located in frontal lobes, not spread to the widespread areas. So no jerks. So the primary motor cortex not involved, and no hyperkinetic automatism. So maybe the frontal pole and the inside the meso area, prefrontal meso and orbital frontal cortex are not so widespread involved. And I would think maybe the left premotor cortex is initially involved in his seizure.
Thank you, Dr. Wong. You said it is difficult, but you made it very simple. So yes, in frontal lobe, we would agree that the initiating area may be silent, and what we see as a clinical manifestation may be a manifestation of the propagation or the spread. And the events are so brief, so one really doesn't know whether what we're seeing as an abduction of the hand is really originating from the SMA or is a spread there. So these are some more events. They're pretty much similar. So I'll just skip that. So if we thought that the semiology was perplexing, the EEG was even more perplexing. So here is the event, and obviously he's in sleep. We can see a little bit of spindles there. And this is prior to the event. This is epoch and a half prior to the event. And we can find low voltage frequency activity, high frequency, mixed frequency actually. But there are some spikes which are seen, and these spikes are seen at F7 through the spindle, and some sharps which are again seen around F7. So really there was some suggestion of some isolated spikes pre-ictally around F7. And here is the event. So the last second shows the beginning of the event. So the EEG is even more perplexing, and this is what stumped us. The EEG, if you look at the onset at the last second, almost looks like a fast activity which is generalized, almost like a GPFA. So a generalized paroxysmal fast activity. However, preceding that, you can see these sharps which come in at F7 here. So we are seeing this sharp, and there's some kind of rhythmic activity around these sharps. So that was the finding pre-ictally, these F7 sharps and the so-called generalized looking discharge, with almost made us think, whether he has something like a Lennox-Gastaut syndrome or a generalized, second symptomatic generalized epilepsy, or which is with a GPFA-like activity. However, the sharps which occurred at F7, made us think that there is a red flag. This is truly not a generalized epilepsy. It's probably something around the posterior frontal or frontocentral area. And so this is the continuation of that GPFA. So you find the GPFA coming in, and it lasts for barely a few seconds. So 5 seconds of that, followed by attenuation, followed by polyspikes GPFA, followed by attenuation, followed by polyspikes GPFA, and then these sharps, slow waves which come in towards the end of the epoch. And these are again followed by this, attenuation between these PFA-like generalized polyspikes, and followed by the slowing. But if you have a careful look at the slowing, you find that through that, there is a higher amplitude slowing on the left side, left frontocentrally, and there are sharps also seen left, which are not seen on the right, at least towards the second half of the epoch. So this was the perplexing finding we had on his EEG. And the next epoch again shows these, recurrent sharps with almost phase reversals at F7. So they continue like this. So the same thing now, I've put it in a reference montage. The same event is in the reference montage here. And you can again find that through the sleep spindle, there may be some sharps at F7. And again, the activity starts with this generalized kind of paroxysmal fast. But before you see that generalized paroxysmal fast, you see focal, sharp activity, which is at around FP1, F7. So though the EEG looked almost generalized, with generalized PFA, there was some subtle red flag of sharps in the left frontal region. And the reference electrode, again here, reference montage, again showing the same activity, the bursts of the, generalized spiky activity with attenuations. And this is a second event, again showing, the same. You can see here the phase reversal at F7, pretty much. And then you see this again, you see the reversals at F7. And again, the activity starts with this almost generalized looking, fast activity. I cannot make out at the onset of this generalized activity whether the onset is earlier on the left or the right. But if I'm biased, I may say maybe it's a slightly higher amplitude on the left, but that would be with bias. So that is how the second event looked like. And this is where the ictal spect was injected. So because the event was so brief, it's very difficult to inject for my technicians and for my nurses. In a frontal lobe seizure, this is the problem. Because the events are so brief, we just cannot inject it fast enough. And the injection actually went in towards the end of the GPFA activity. And this is again followed by the sharps which come in. And so that is pretty much his EEG, which is even more difficult to interpret, or perplexing as compared to his semiology. So I'd like inputs from Dr. Ikeda and Dr. Wong and Dr. Yu.
Yeah, that's very interesting. We didn't expect it that the EEG was so robust. When you pointed out some interictal spike before the seizure, and then once that the low voltage fast activities start occurring, especially in the second seizure, with the transverse montage, the low voltage fast activity may be presumably a little bit clearer at the vertex area in the second seizures. So when we look at the first seizure, it could be better to see that the change of the sensitivity, because it is quite large in activity. So if it is possible, could you show it at the second seizure with the transverse montage?
I actually have these put on the PowerPoint slide. So
yeah, okay, that's fine. Show it at the second seizure again. Second seizure.
This is a seizure 2.
It is a seizure 2?
Okay. I mean,
Okay.
this is just before the event.
Okay.
So this is an epic before the event.
Yeah, the intake, the F7 spike, we could point it out something in 0.5 seconds afterwards, some phase reversal like low voltage fast activity with the negative phase reversal at the CZ. And before that, 0.5 seconds after that, the initial F7 spike.
Okay. Yeah.
Probably I could write, probably. Yes, I think I could write. What I'm talking about these areas. I'm talking about this area. Could you see that?
Okay. Yes. This area, yes, we did point out this area.
Yeah. So that's one. Then in 0.5 second, we may have the vertex spike at the CZ, I think.
Okay. Yeah. So here you're talking about this one.
Yes, over there.
Okay.
And then in the next page, then I will let me erase this one.
We see the same thing here.
Yeah, okay. And the next page at the
So here
time of
we thought even here there was some F7.
Yeah, okay. And the next page, please.
So this is the onset page.
Yeah, that's what I mentioned. So in this particular, the onset of the seizure, something is now going on. This the transverse montage. So if we pay much more attention, as opposed to that this F7 area, so I can't see that the clear F7 activity, but I still don't know that the CZ may have something, or C4 may have something, since it is the bipolar montage. So that's what I feel at this moment. So even in that SCAR-PG, time frequency analysis without any EMG, especially this point, may be helpful to see that any ictal high gamma activity by time frequency analysis. So that's what I feel at this moment. The F7 is quite the important to find that the inter-ictal spike, but toward the beginning of the seizure, low voltage factor activity may be a little bit impressive at the vertex area. That is what I feel.
Yeah.
Yeah, you are right. See, according to the EEG, I guess I could get an image. So the dorsolateral, that means the convexity of the brain is involved rather than the meso part of the brain. So the initial few spikes, the left F7 few spikes before the seizure is very indicative, which suggests the left, maybe the left, say the posterior part of the inferior frontal gyrus, around some area around that part is responsible for the seizure, maybe. Otherwise, the occipitofrontal, I don't think occipitofrontal is responsible for the seizure origination, since the few spikes preceded the generalized discharges. That's my opinion.
Yeah, thank you. I think that was a very good interpretation both by Dr. Ikeda and Dr. Wong. F7 would indicate the posterior frontal, inferior frontal on the left. So we have a clue there, but then this generalized looking activity is the one which kind of we do not expect at this age in this young individual. This is more commonly found in children less than 6-7 years. But here we have a 22-year-old showing this kind of, generalized PFA. So with this...
Can I ask a question to all the faculty, more for the benefit of the viewers? So can anybody explain why the patient did not have any ictal aphasia? Because as per the EEG, it looks very much close to the Broca's area. But what is surprising is that the seizures are very short duration, and immediately the patient is fully conscious without any kind of aphasia.
That's a very important question. Could you hear me?
We can hear you, Professor.
We can hear you.
Okay. The question is that this patient epileptic area may close to that F7, whereas that although the F7 is active, the interictally, but actually the symptomatogenic or the ictal area may be aside from the F7, like a vertex or the major frontal. So if it is come from that so-called the major frontal like supplementary motor area proper, it may not necessarily cause that the aphasia. So that is the one possibility. So I still have that the two option that the seizure may come from the ventral lateral frontal area or just the high major frontal lateral high major frontal area. That is the two option. But when we look at that the EEG, interictal and then the ictal pattern is totally different. So in the second seizure, ictal pattern start occurring as the low voltage fast activity. Low voltage fast activity is very important because that it is very impressive, but from the signal to noise ratio, since that the amplitude is very small, it is very difficult to point out where is that the maximum point. So that's at the limitation our visual inspection. So therefore, I may get some aid by that the time frequency analysis of ictal scalp EEG. That may help us our visual inspections.
Thank you, Dr. Ikeda. So any comments from Dr. Wang?
Yeah, I have no special comment on the aphasia. Maybe the one you see the generalized discharges lasted only a few seconds, say 5 seconds or so. So the patient may didn't notice if he could speak or not. So another possibility is the discharges before the seizure limited to only a very small region. So no, since you know the cortical areas related with the language is distributed widespreadly, just like mosaic distribution. So very limited discharges didn't affect the language function. I think that only 5 seconds is not enough for a patient to notice he couldn't speak or not.
Yeah, I agree with you at the explanations. Yeah.
So the event is very brief, and maybe that's why he's just recovering. But also could be possible that since his seizures have started before 5 years, I mean at 5 years of age, and we know that speech lateralization takes time up to 6, 7, 8, 9, 10 years. So could it be that his speech is actually because of the onset of seizures has actually shifted to the right frontal?
Yeah,
so
yes.
that could also be one explanation, because his seizures started at a very young age. It wasn't like after 10 years, it was by 5 years of age. So that was one of the explanations we thought, which could explain that speech was not involved. Of course, the seizure was very brief, like Dr. Bang said, so we really can't completely go on to the theory of speech lateralization age. With this, with the hypothesis of the lesion being in the left frontal, we went ahead with an MRI. And so I'll just run through the MRI. Any comments on the frontal lobes here?
May I say something?
Yes.
Yes, the first impression is that for example, the coronal section may have the quite thick, high intensity area of cortical, appearance. So that may be a quite thick focal cortical the malformation of the left frontal area. But the furthermore, I have the impression that the whole left frontal and then the central area is more atrophic than that the left-sided. So in order to decide that the clear focal seizure area, finding that the very particular spots may be a little bit difficult, but the throughout that the atrophic the left frontal area, the cortical ribbon is more or less quite thick. So that's what I feel. Yeah.
Thank you, Dr. Yes.
Quite agree with Professor Ikada's comments. You see it from this slide, the left, the dorsolateral, maybe the inferior frontal gyrus, the cortex is the blurring, the borderline between white matter and gray matter is blurring. So very important sign, maybe focal cortical dysplasia.
Yeah. So this is just the T1. It's difficult to show all the sequences and all the images, but because of the time issues. But basically, there was in the left, yeah, so you can see it starting there, and you can see it here. So this is T1. And one can see it more clearly here. These are just the still images. One sees the white matter on the right side very well proportionated to the cortex, but on the left inferior frontal as well as the pars triangularis area, there is a complete loss of the gray-white matter differentiation and thickening of the cortex, as we can see here. So
I think that the left major frontal is also a little bit blurring of the cortical thickness in addition to, yes, that's one.
Okay. So basically our imaging neuroradiologist, Dr. Gaikwad, felt there was involvement of the pars triangularis, a part of the pars orbitalis, as well as pars opercularis. And we can see here the images which I showed you, the last image, it corresponded to this area where the gray-white matter thickening was seen, which would be the Broca's area. So this is the pars triangularis. This is the pars opercularis, and this is the pars orbitalis. So the rest of the sections were okay, and nothing was seen. We had done a diffusion tensor imaging too. So we then looked at how to explain the semiology based on the anatomical anomaly which we found, and this is the landmark publication by Bonini, and we know that in group 2, which is where we thought our patient kind of fitted into, which is area 44 and 45 here, where the lesion was on the left side, the semiology could have some elementary motor signs and non-integrated gestural motor behavior, but he didn't have a non-integrated gestural motor behavior. So there was some asymmetric tonic movement of the right upper limb, but there was no other feature of the group 2. So the explanation for the abduction of the hand was a propagation probably to the SMA-like area, or it could be a part of this tonic posturing which is there in group 2, but this was asymmetric. So how would you agree with this interpretation, that is either a propagation to the SMA or a part of the group 2 44-45 area tonic movement of the right upper limb?
May I say, the speaking of the 44 area, it's also have some negative motor areas. In addition to that, the supplementary negative motor area, negative motor area correspond to the pre-SMA. So the area 44 may explain that some sort of the inhibitory seizure, but it is usually involved at the contralateral side of the body, but the whole side of the body, like atonic seizure-like events can happen that the pre-SMA or the supplementary negative motor area. So I think it is a little bit difficult to explain only by the involvement of the area 44 or the other adjacent lateral convexity, but it may spread to that the pre-SMA because that the between that the area 44 and then the pre-SMA, it is a rich connections.
So agree, the negative motor areas just lie right above and along the Broca's area. And of course, the negative is also the pre-SMA, and he used to have falls, of which he was aware, followed by altered sensorium. So one could hypothesize that they were involved in it, though it was not a symmetric.
So my explanation is that the originated from that the Cleveland Clinic School. It is not the French school, so it's a little bit different from these literatures.
So any other interpretation of the semiology considering the anatomical location of the dysplastic cortex? How would we interpret the semiology of abduction of the right upper limb?
I guess maybe the ictal activity is spread a little posterior to the rolandic areas. So since you know the basic activity, the patient showed abduction of his right arm. That's a very basic activity. So I guess maybe a little spreading to posterior part of the frontal lobe.
So this was his ictal spect, which we saw, which was injected towards the end of the GPFA, and it pretty much showed us the same localization on the left inferior frontal and pars probably triangularis and opercularis, and there was some spread to the dorsolateral. So his PET showed us, this is just a PET, showed us a hypometabolism in compared to the right dorsolateral here. And also we know that PET kind of estimates it gives us a larger area because it indicates the functional deficit zone. And we did, a PET MRI fusion, which again showed us pretty much this pars triangularis, pars orbitalis, pars opercularis area, which is hypometabolic as compared to the other side. The mesial cortices did not look asymmetric on either side. So that was his coronal bed. So if you can see it here, it's this area which is hypometabolic compared to the right. And again, this area compared to the right. Again, this area compared to the right. And pretty much extended.
Yeah, I still concerned about the relatively low low hypometabolism of the left the major frontal area, which is the upper to that the single gyrus over there. So
Okay.
although the ictal spect is not active, but seeing that the FDG PET the left major frontal maybe and again that a little bit hypometabolism.
Okay.
Above that the single gyrus. It's not yet, but from there, I think start occurring.
Yeah, here. Maybe.
Yeah.
Okay. So we were more in favor of the origin being the dorsolateral frontal pars triangularis pars opercularis. This was his MEC, which showed us dipole. The red is the onset of the spike, and the green is the termination of the spike. And so it was around the pars triangularis area, as we can see here. MEC dipole was pretty consistent with the anatomical localization as well as the PET findings. This is just the DANA analysis, which showed relatively, it's not a very tight cluster, but it is a good cluster of dipoles, which is seen in the same areas. His functional MRI was very, very interesting in that there was on motor speech paradigms, there was bilateral activation, and the activation was more abundant in the right frontal compared to the left. And the activation in the left frontal had shifted upwards as compared to the right, which was actually near the pars triangularis, whereas the left had kind of floated upwards. So definitely this area was spared in the functional MRI, which made us feel very happy for him, because here we have a patient in whom the lesion is over the anatomical Broca's area, but the functional MRI motor speech paradigm clearly showed a shifting to the right Broca's right corresponding area, and even on the left, it had moved upwards into away from where the anatomical Broca's area would be. So with this, we still thought that it would be good monitoring, mapping his speech, and so we didn't implant him from the point of view of trying to localize where the lesion was. Our hypothesis was pretty much around the pars triangularis, based on our MEG, based on our SPECT, based on our PET, and based on the EEG showing the F7 pre-ictal spikes, and he was implanted with.
Manjari, can I ask Dr. Yu, if you go to the previous slide?
Yeah.
Dr. Yu, as a surgeon, you have this patient, a largish focal cortical dysplasia on the anatomical Broca's area, but the functional MRI is not showing any activity there. And the semiology is also very much characteristic of not having an ictal aphasia. So would you still like to implant him, or do you think you can go for direct surgery?
Okay, I think both the selection is reasonable. I think the functional MRI was can show the compensation of the the cortex, so you can do the complete resection of this lesion. If you want to identify the boundary of the lesion, maybe the SEG is helpful. Okay.
So would you go for a straightaway surgery, or would you still like to do an implantation?
Maybe if you can do the intraoperative language monitoring or intraoperative language mapping, I think direct resection is also reasonable.
Thank you.
Okay.
So we will show what we have done. Could you go to the next slide, Manjari?
So yes,
we did implant SCG, and in fact, we have implanted some SCGs close to the lesion, but a bunch of SCGs around the lesion. And the reason we implanted SCGs was not to prove that the cortical dysplasia was actually firing, but to show that this area is safe for resection. We did consider an awake craniotomy, with language mapping intraoperatively. But the patient was having almost 9 to 10 episodes every day. So there was always a risk of having too many intraoperative seizures, which again makes the awake craniotomy, kind of very uncomfortable for the surgeon. And in addition, the parents were very, very finicky. So even though the fMRI was showing that there was no language activation in that area, but still they wanted to be 100% sure. So they said that, they were saying that this was an intelligent person who had a job, who was doing his job on computers, and there is no way that we can take a risk that he could develop any kind of aphasia. So they wanted to be almost 100% sure before we go ahead and do surgery. So considering all the situations individualized to the patient, we finally went and implanted him with this 7 electrodes. And Manjari will quickly show what we have done.
So basically, there were electrodes which were put in various locations. Our hypothesis was not to prove that there is a dysplasia, but to prove that there's no language around in and around the lesion, and also look at the generation pattern of the seizures. So as we can see here, we stimulated and we did speech mapping by naming, repetition, and speech, and reverse counting. So he was asked to do a reverse counting, and this is the anterior to the lesion, and anterior and superior to the lesion. So that's why it's called ASF. And we went up to 10 milliamperes. We started with 1 and went to 10. The language was perfectly preserved in all domains, naming as well as reverse counting. And there was a seizure in the electrode locations which are marked red. So we then stimulated the posterior to the lesion, which is posterior margin, and there was a seizure again here, but nothing else on all of the electrodes. The posterior opercular, so again, there were seizures along this area, and pars triangularis, there were no seizures, no involvement of speech in the pars triangularis. Pars orbitalis, no seizures and no involvement of speech. The inferior to the lesion, no seizures and no involvement of speech. We also had an insular electrode passing along the anterior cingulate area, and not really close to SMA, but juxta SMA, that didn't show any onset. So the onsets were pretty diffuse because the electrodes were all around the lesion and were mainly in the pars triangularis, orbitalis, and anterior to the lesion. So with this, we then went ahead with the electrocorticographic grid placement, and you can see the very, very frequent spikes, almost a grade 3 to grade 4 ECOG, very, very frequent spikes on the ECOG during the surgery, and he underwent a resection of this area, and this is just to show you the post-op. So basically the areas resected were the pars triangularis, pars orbitalis, and also the pars opercularis.
So we did a complete resection of the focal cortical dysplasia using neuronavigation and also electrocorticography. And after an adequate resection, the electrocorticography had significantly improved. So we use electrocorticography very, very commonly, especially for resection of focal cortical dysplasia, even though we have done SCEG preoperatively, because we find that ECOG, real intraoperative electrocorticography, really helps us to map out the resection, especially for focal cortical dysplasia. And in this, doing a preoperative SCEG really gave us that confidence that we could go in for a very wide resection without actually affecting the speech. And it also gave confidence to the parents that the speech is nowhere near the focal cortical dysplasia.
So basically, the problem is we started out with a patient who, when we saw the EEG, we were perplexed. But when we saw the MRI, we were even more challenged in that whether we could help him out. But the functional MRI made a whole lot of difference to the approach which we had in this patient, put along with the fact that there was no post-ictal aphasia, of course, even though the seizures were brief, and put along with the fact that his SEG stimulation did not show speech in any of the areas by bedside testing. We could successfully remove the left Broca's left inferior frontal pars, triangularis pars, opercularis, and pars orbitalis area, and the lesion was a type 2 cortical dysplasia. He is seizure free for almost now 2 years. However, on the last follow-up, the mom said he was having some subtle nocturnal event once or twice in a month, and we have slated him for a repeat post-operative video EEG in the coming month. So basically, he had a pretty good outcome, and he is working. For his deep venous thrombosis, he is still on anticoagulation with acetrom, and he is, at least the parents are relieved that those frequent nocturnal events are not there anymore. So with this, I'd conclude the case, and if there are any comments and questions.
So since we are, running out of time, so we will request comments from each of the faculty, maybe starting with Professor Wang, then Professor Ikeda, and then Professor Yu.
I think this case is very interesting. FCD FCD in the left inferior frontal gyrus, the posterior part of the IFG, and with no aura, and the main similarity is the abduction of right arm with a few second EEG generalized discharging, and no aphasia during the seizure. So very well prepared pre-surgical evaluation for the localization of the epileptogenic zone. So the similarity is very basic hint about the generation of the seizure, and EEG discharges supported the left hemisphere is the responsible for the seizure, and also the MRI and the PET scan both showed the hypometabolisms in the posterior part of the left inferior frontal gyrus. And so also this case is very good. The MAG, the dipole clusters also located in the same area. So most important thing is the language function MRI is very important for us to determine if we should make a resection. We can that means the language area transferred to other part of the left hemisphere, and also to the right side of the brain. So that's guaranteed you do the resection with no language impairment. That's very good, very impressive case.
Dr. Ikeda, Dr.
Yes. Congratulations for that, the very sophisticated data analysis, and then the great success of the surgery. One comment and one question. I totally agree that ECOG is very important, especially when we encountered so-called red spike, namely continuous spike activity at the focal cortical dysplasia, it is the very good the guide or the biomarker to delineate focal cortical dysplasia. The one question is that the electric stimulation of the SEG elicit the right hand abduction. It is correct. If it is so, I think that the distortion of the functional localization can happen because of the quite massive the presence of the focal cortical dysplasia. This is my second. This is my comments. So thank you.
Yes, he had a similar seizure with a slight, 30 degrees abduction of his hand during the stimulation. So, you are saying that because of the extent of the dysplasia, that could be the explanation.
Yeah, that may distort that the normal the localization of the motor area causing that the shoulder abductions.
Okay. Thank you.
I also think it's a very interesting and impressive case. But my comment is, according to the extensive EEG activities and the aim of identify the eloquent cortex, do you think the implantation of grid electrode might be more suitable for this patient?
So we find that for language mapping, of course, the thing is that grid mapping is more useful. But now this patient had both low limb deep venous thrombosis, and he also had a fracture. He had significant comorbidity in these two problems. We were concerned about the fact of making a large craniotomy and keeping him for 2-3 days for documenting his seizures and language mapping with a large craniotomy vis-a-vis small, placements of SEG electrode. So traditionally, though one may think that SEG is the grid is better for language mapping. There have been studies which have now been done, which show and which reveal that even language mapping is accurately possible, and these are large number of cases which I'll be showing with stereo EEG. So language mapping with stereo EEG, a large number of studies, and these are the number of studies which have been looked at. So you can see here that just like our patient, the stimulation parameters went up to 10 milliamperes, and there were patients, they were like 29, 42, 172. So large number of patients have undergone already SEG mapping of the language with good outcomes. So based on the review of this literature, we were also apprehensive whether we should put a grid based on the fact that he had low limb DVT, he was on anticoagulation, we had to stop his anticoagulation for the SEG, then we had to restart it after the SEG, then we had to wait for some time before we again stopped it for the resection. So, this kind of environment where he had to be stopped off his anticoagulation with the active DVT in his lower limbs, we thought the SEG will be less invasive as compared to the grid placement. And then when we reviewed the literature and we found that there was already extensive studies with 170 patients, 30 patients, 10 patients, and with good results, we went in for a SEG. It was a dilemma for us also, whether we should put a grid or a SEG. But we ultimately went in with SEG.
Thank you.
I have two questions, one from Indonesia. So the question from Indonesia is that, can we go for direct surgery without depth electrode implantation due to lack of resources in many countries? So could we just do a good MRI, neuropsychological testing, and maybe a PET scan, and then do direct surgery? So would anybody like to comment? So I think most of it has been already explained by Manjari. So that is a dilemma. So even though we have confirmed by fMRI that there is no language function, but again, the patient's parents were very, very finicky. They say that he's a fully grown up adult, 22 years. So we want to be 100% sure before you go and do the resection. So I think the patient has to be individualized. That would be my answer. Dr. Yu, would you like to comment something on this?
Can I suggest, if the patient is cooperative, then even a awake mapping intraoperatively can be used. So
Yes.
awake surgery.
So, Dr. Yu, you would like to comment something on this?
Yes, I think maybe the EEG, the implantation is a better selection for this patient, even though he can also do the direct resection.
Thank you. Then this question, I think, is for Manjari and specifically for this patient. Again, I think from Indonesia. The patient was seizure-free for 2 years after surgery. And then during this period, what were the anti-epileptic medications you were giving to the patient?
So we had reduced his lacosamide and we had reduced his clobazam. He was still on levetiracetam. Just 2 weeks back, when the mom said there were some nocturnal episodes, I restarted a low dose of clobazam. So we had successfully, after 1 year, we start tapering the medicine. So we had tapered off his lacosamide as well as his clobazam.
Thank you. So thank you very much, Manjari, for giving us this case. And now we will go to our didactic lectures. So first, may I have the pleasure of having Professor Yuping Wang to start his presentation on the preoperative workup for dorsolateral epilepsy, dorsolateral frontal epilepsy.
Yes, thank you, Dr. Sarah. And I will, after the full discussion of a case of frontal epilepsy, I will summarize some important work related with lateral frontal lobe epilepsy management. And as you know, frontal lobe is very important for the human. So you know the frontal lobe is very especially enlarged in primates. So it's a supermodel associative area that, and the frontal lobe connected to many parts of the brain via cortical fibers, and dorsolateral frontal cortex are divided into several parts. One part is the precentral gyrus and the precentral sulcus, and the prefrontal area are subdivided into superior frontal gyrus, the Brodmann 4, 6, 8 areas, and the middle frontal gyrus, Brodmann 9, 10, 46, and the inferior frontal gyrus, Brodmann 11 and 47, and also as the case we discussed, the patient involved the Brodmann 44 and 45 areas, and the two sulcuses, the superior frontal sulcus and the inferior frontal sulcus. So for frontal lobe seizures, generally the seizures originating from frontal lobe have an early motor sign, in some cases with vocalization, and most of the seizures occur during sleep, as we discussed in this case. 90% of the seizures occur during sleep, and the seizure in the patient experience the seizure in cluster, and often after the seizure, the patients the patient without any prolonged impairment of the awareness. And another important point is the seizures originating from frontal lobes have diverse clinical manifestations. So this is a very important paper from Bonini. In their research work, they divided the clinical features into several groups. Generally, the posterior part of the frontal lobe are related with semiologies such as early clonical sign or reversible sign or tonic posture. Sometimes in few cases with somatocystic aura. And the rostral and also the prefrontal pole patients, the seizures only from this part, usually showing the staring. That means the patients showed some degree impairment of the awareness. And in some cases with speech arrest, and also the patient may show manipulation behavior and fixed facial expression sign. The key point is the clonic signs always correlated with more posterior region, and the manipulation behavior is only correlated with the more anterior prefrontal region. So for more detailed investigation about the seizures from the dorsolateral frontal cortex, we can divide frontal cortex into three parts. One part is primary motor cortex, that means the precentral gyrus, the Brodmann area 4, and also premotor cortex, the Brodmann 6, 8, 9, and 44, 45, and also some 46 area, and also the prefrontal cortex, usually the Brodmann 10 or 11 area. So the primary motor cortex, Brodmann 4, usually the electrical stimulation of this area usually results in localized muscle twitch of the contralateral side of the body, and organized pattern represented by the figure, the homunculus, and usually the spreading, the unilateral spreading clonic activity may spread from a part of the precentral gyrus to the other part of the precentral gyrus. So originally the clonic jerks moved from one part of the body to the other part. Usually this the seizure originated from this area. The patients didn't have any impairment of the conscious during the seizure. Bonini summarized the main symptoms originated from the posterior part of the frontal lobe, mainly the Brodmann 4 area, and most of the signs are basic movement symptoms. And also, this is a case shows the clonic jerk activity for 3 years, continuous for 3 years. So no EEG discharges after the back averaging of the EEG we could see the activity and the positive and negative activity from the contralateral central areas. So this is also a seizure originated from the primary motor cortex. And the premotor cortex involves the Brodmann area 6, and the main symptom of the seizure from this area is the aversive seizure with forced head turning to the contralateral side. And the frontal eye field, the Brodmann area 8, or some area a little maybe 9, Brodmann 9, 8, 9 areas. So the seizure is usually the eye movement deviation to the contralateral side. Just as we discussed in this case, the Brodmann 44 and 45 areas. This area related with language, but not always the cases can show the aphasia symptoms. The stimulation of this area may result in the speech arrest. So Bernini summarized the symptoms of Brodmann 6, 8, 9, and 44 and 45 areas, the symptoms. And the prefrontal cortex. Prefrontal cortex is a special area only in primates, especially in human. This area is responsible for working memory, emotion processing, or executive, the control executive function. So the seizures from this area is very complicated. So the patient may have some sensory errors related with somatosensory, even in some cases with visual sensation. And another feature of this area, the seizure, is the bizarre gesture, as the patient may laughing, shouting, or paddling, or stretching of the extremities. Bernini summarized the seizures originated from this area into group 3. And another area is the orbital frontal parts of the frontal lobe. That's the symptom. The seizures from this area is very complicated, and that's not a part of the dorsolateral frontal cortex. So the imaging is very important for the frontal lobe epilepsy focus localization. So MRI can detect very slight changes. You see the blurring of the white matter cortex to the gray matter cortex. And PET scan is also important for we found the hypometabolic areas. And also pre-surgical functional MRI is very important for language mapping, as Montage reported in this patient. The picture shows the shift of the eloquent cortex from, and also this study showed even in most of the patients, the language area not always located in the left hemisphere. Scalpel EEG is important for patients with the dorsolateral frontal lobe origination, but for the mesotemporal lobe or the orbitofrontal lobe, scalpel EEG is not so effective. And the seizure monitoring is very important using the EEG, combining with the video and the EEG changes. The EEG and similarly can give us some suggestion about the origination of the seizure. And some authors reported the combination of EEG with functional MRI. So during the spikes of the EEG, the MRI can show the bold signal changes in restricted area related with the seizure. This is a new technique. And intracranial EEG is necessary for a lot of frontal lobe epilepsy patients. You can see this is the scalpel EEG and the intracranial EEG. So very limited activities from very limited area, just a few less than 1 centimeter. And the high frequency oscillation is also important for the localization. But in our clinical practice, we found the high fold ratio increase gradually just before the seizure. So in the seizure onset zone, the high fold ratio will increase gradually towards the seizure. And cortical stimulation is very important, not only for localizing primary motor cortex, but also for localizing language area. For motor area localization, usually we use low frequency stimulation, but for language area mapping, high frequency stimulation is necessary. So during the stimulation for language mapping, we ask patients to cooperate to do object naming, verb generation, or other tasks. You could see the posterior part of the inferior frontal gyrus is involved in is an important cortical is important part of the cortex related with language generation. Next, I will show you a case how we clinically practice for the frontal lobe epilepsy patients localization. This is a male patient, 23 years old. So seizure history, 23 years. For the first 15 years, the seizure seizure occurs during sleep with limbs movement for a few seconds, say 10 to 20 seconds, with a fear aura several times a day. For the following 6 years, usually the patient experiences more than 10 seizures a night. The seizure type is a hyperkinetic seizure with several anti-seizure medication, and MRI scan is negative, and the interictal scalpel EEG is also negative. This is ictal EEG. So we could see during the seizure, almost no EEG changes. So maybe the several seconds just before the seizure, the background activity changed, but we couldn't tell the difference between the two hemispheres. But in the later part of the seizure, right frontal montages from the divisions from the right frontal lobe showed slow activity, very low amplitude artifacts of the movement. So the MAG showed dipole located in the right posterior part of the frontal lobe, and the FDG PET showed low hypometabolism in the anterior part of the frontal prefrontal lobe. So in this case, based on the semiology, EEG, MAG, and PET scan, we make a pre-surgical evaluation using the intracranial EEG. 2 electrodes were inserted into the hypomotilism area, 1 inserted into the anterior insular area. So you could see the interictal intracranial EEG showed spikes from the first electrode, and also spikes from the second electrode and the third electrode. So the first and the second, the mesofrontal pole, and the third is electrode is inserted into the anterior insular. Here's the ictal discharges. The initial spikes originated from the first electrode, and simultaneously with activities from the second electrode and the insular electrode, with the involvement of the activity, and we can see the fast activity mainly focused, could only found in the first electrode, followed by the second electrode and third electrode. So even so, this patient showed MAC spike dipole clusters in the right anterior insula. In this case, we do very limited resection of the frontal right frontal pole with no impact of the anterior insula. After the resection, the patients were seizure-free for several years. So this case told us the evidence from multi-modality imaging, and if the information is not concurrent, it's a very good case, just as we discussed, reported by the Dr. Mondary. And in this case, the MEG activity is not concomitant with the hypometabolism of the PET scan, and even intracranial EEG showed mainly the activity can be found from both frontal pole and as well as the anterior insular. So this case we did only a few limited resection of the frontal pole based on the just I'll show you the you could see the interictal intracranial EEG shows very sharp spikes, only very limited a few electrodes from the first electrode of a few contacts from the first electrode. So that means the inter-electrode activity is also very important for us to make a final decision. So another point is not all brief semiology are related with the seizure. Sometimes the paroxysmal movement disorders and psychogenic functional seizures may also show very brief motor signs. So we should make a differential diagnosis to different the seizure to see it's a true epileptic seizure or non-epileptic event. So that's my my talk. Thank you.
Thank you very much, Professor Wang, for such a nice and a clear lecture. So, Professor Ikeda, would you like to comment or would you like to ask?
Yes, just one questions. So going back to that the nomenclature of the semiology based on that the epilepsy and the literature. So this patient, the right hand abduction may belong to that the prefrontal group 3 semiology. It is true?
I think it's from group 2 rather than group 3.
So-called that the functional premotor area. That's what you want to say? Proximal involvement.
Premotor, not yeah. Generally, we see except the precentral gyrus, other areas are usually defined as the premotor cortex, but prefrontal cortex, but prefrontal pole is a very specific area. That means Brodmann 10 or 11. That's very specific, different from the other areas, such as the 44, 45. So prefrontal cortex are subdivided into frontal pole and premotor.
Okay, thank you very much.
So thank you very much, Professor Wang. So may I now request Dr. Tao Yu to give his presentation on surgical management of dorsolateral epilepsies, dorsolateral frontal epilepsies.
Okay. Thank you for your introduction and thank you for your invitation. For the time limitation, I'll focus my topic to one part of the lateral frontal lobe. So my topic is surgical resection for epileptogenic zones in the inferior frontal gyrus. There are two main parts in my presentation. The first is localization and the resection of the epileptogenic zones in the inferior frontal gyrus. And the other one is localization and the protection of the eloquent cortex in the inferior frontal gyrus. So let's see something about the anatomy of the inferior frontal gyrus. Usually, the inferior frontal gyrus includes the parts orbitalis, triangularis, and orbicularis. And these three parts are separated by the horizontal ramus and the anterior ascending ramus of the Sylvian fissure. According to my experience, the cortex near the horizontal ramus and the anterior ascending ramus of the Sylvan fissure, it's easy to develop focal cortical dysplasia. For example, in this patient, we can see the FCD lies in the deep of the horizontal ramus of the Sylvan fissure. Here is the lesion. This is another example of the focal lesion, lies here in the anterior ascending ramus of the Sylvan fissure. We can see the blur of the green and white matter. And the localization is also supported by the PET, the result of the PET, and the dipoles from the MAC. And this is another patient with a typical image of focal cortical dysplasia, and maybe is the type 2B. And in this condition, we can remove the lesion completely. But in this patient, the lesion located in the left inferior frontal gyrus here, involving the insular cortex, the hypometabolism here. But we do not worry too much about the language because he is only 3 years old baby. So we can remove the lesion completely without obvious damage to the language function. And this is another example. Let's see the video. This patient waken up with pouting, then shaking his head, rocking on the bed, show us a hypermotor seizure. And we can see some detail of the ictal behavior from this video. Pouting. Then pay attention to his face. His face turned red with painful countenance, then shaking head and rocking on the bed. And we can see the very tiny spikes here on the contact FP2, F8. And sometimes we can see the polyspikes with very low amplitude also on the contact FP2, F8. The MRI seems negative, but we suspected a very subtle lesion here. But this suspected subtle lesion is inconsistent with the result of the PET and MEG. So we can see the spike dipoles cluster lies on the other side of the lesion, and the hypometabolism is multiple and extensive. So we have to perform ECG recording for him. The electrode was implanted bilaterally, exploring the inferior and the basal frontal, the lateral and the mesial frontal, and also the insular cortex. Fortunately, we recorded the polyspikes here in the electrode gene. And this shows the ictal activity. Also, the polyspikes then develop to the low fast activity. So we can see the seizure originated from electrode G. These show the detail of the seizure onset. So the low fast activity originated from G13. This is the location of contact G13. We can see this contact also lies in the horizontal rimers of the Sylvan fissure. And the electrocortical stimulation mapping is the result. So the mapping, the aura can be induced on these three contacts, also in the electrode G. So we finally remove the epileptogenic zone completely. Now let's discuss another important topic about epileptic surgery in the infrared frontal gyrus: how to localize and protect the eloquent cortex. As we know, Broca's area lies in the dominant infrared frontal gyrus. So the protection of language function must be considered before a resective surgery. And how to localize the eloquent cortex is the premise of protection. This picture shows the traditional electrode cortical stimulation mapping with the grid electrode. But as we know, this is a very time-consuming process and dependent on the patient's cooperation very much. And on the other hand, the implantation of grid electrode is gradually replaced by SEG. So the electrocortical stimulation mapping for language is more difficult with SEG electrode for the incontinuous electrode distribution on the cortex. So it's necessary for us to look for new ways to locate language functions. As we know, another way to localize eloquent cortex is task state functional MRI. This picture shows the activation with different tasks. And we can also process the original result by image fusion with 3D MRI. Then the activation of different tasks is quite clear at a glance. So I think it's more popular for neurosurgeons. For example, this is a patient with a FCD lesion on the dominant posterior infrared frontal gyrus here. And the results of the MAC and the PET examination also support the localization here. But the key problem is, can we remove the lesion without damage to the eloquent cortex? So we performed a language functional MRI for her. We can see on the left side, the cortex in infrared frontal gyrus is not activated with the task of verb generation, while on the other side, some frontal cortex is activated. And this shows the result of the task of auditory comprehension. So both sides, the inferior temporal is activated with the task of auditory comprehension. So we think there is some extent of language compensation in this patient. And finally, we gradually remove the epileptogenic zone and intraoperative language monitoring. And this is another patient with a typical FCD on MRI locates just in the Broca's area. Similarly, we also performed the language functional MRI for him. We can see on the left side, the cortex in infrafrontal gyrus is not activated at all at the task of test reading, while on the other side, some frontal cortex is obviously activated. It's the result of the task of auditory comprehension. So therefore, we confirm that the language function compensation has been formed in this patient. And again, a complete resection was performed for this patient. In addition, we try to use another way to localize eloquent cortex. As we know, it's found that the cortex show event-related high gamma oscillations in task processing. And we also demonstrated that it can also be used to map the eloquent cortex. We have underwent a serious test and clinical application. And the clinical application showed that the cortical-based real-time functional mapping might be a safer and quicker alternative to the electrocortical stimulation mapping. This video shows the example of offline signal analysis. This is the raw EEG, and this shows the high gamma activity, and this is the audio recording. Maybe you can now hear the sound. So the blue one is the signal of the patient, and the yellow one shows the signal of the doctor. Then we have further testified the availability of this new method in language mapping, intraoperative. Furthermore, we updated the real-time functional mapping approach based on tensor component analysis and using the whole frequency band for better localization rather than only high gamma oscillations. And this picture illustrates the practical application of the intraoperative real-time functional mapping. We can see the lesion here on the dominant hemisphere. So we put the grid electrode here in operation for the first time, and the blue dots show the activated cortex. Then we move the grid here. For the second time, we acquire the blue dots, which show the activated cortex. Then we identified the location of the eloquent cortex, and we removed the epileptic cortex carefully with intact eloquent cortex. It's the result of the resection. And finally, the intraoperative waking up anesthesia and continuous language monitoring during resection are also guarantees for safe resection. And this video shows the patient is singing a song during the cortical resection, but maybe you cannot hear the sound. We can see the rhythmic tap of the finger. So we can do the resection safely. So summary, for epileptic surgery in infrafrontal gyrus, the extent of resection usually was determined according to the location, size, discharges, and the possible pathology of the epileptogenic zones. Sometimes we may pay more attention to the cortex near the horizontal lemurs and the anterior ascending lemurs of the Sylvian fissure, where the focal cortical dysplasia often occurred. a precise localization of eloquent cortex is crucial factor for safe resection in IFG. The functional MRI, real-time functional mapping, and waking up anesthesia are all effective methods to ensure adequate and safe resection. Thanks for your attention. Okay.
Thank you, Dr. Yu, for that wonderful lecture. And very clearly you have shown us what are the strategies we should undertake for lesions around inferior frontal gyrus. Now, I don't see any questions, but I would like to ask you a question. So let us say we are addressing a number of people, especially surgeons from developing countries, and surgeons also working in areas which have resource limitations. So under the circumstances, if a person has a lesion on the eloquent area, and they have access to investigations like MRI, video EEG, and they could develop an fMRI. So what would you advise for such people on how to manage such cases? I mean, obviously they cannot undergo implantation. SCG is not available in many countries. So would you advise that surgery could still be done with the following tools, or you think implantation is very much needed?
Yes, I think implantation is needed, but yes, for some patients, maybe the number of the electrode will have to balance the usage of the electrode.
Thank you. My other question is, and this is an open question because this is what even I have questioned myself, and we had discussed this with a neurologist. We have done so many fMRIs, and the fMRI we know is quite accurate. But still after fMRI, we go in for implantation. In your experience, have you ever done resection of an eloquent cortex directly after an fMRI? Dr. Yu, could you understand my question?
Not very much really.
Yes. So let me repeat my question. So my question is that we have done fMRI in so many patients, and we are quite confident that it is reasonably accurate. But still, we go in ahead for implantation, even though we have done the fMRI. So have you done any cases where you have done a direct resection following an fMRI without implantation?
Yeah, in our center, you know, in China, the Beijing, it changed the strategy, surgical strategy changed greatly. You see, 10 or 20 years ago, we usually did some resection after MRI, scan without implantation, using the cortical stimulation, intraoperative cortical stimulation for the L-cortex mapping 10 or 20 years ago. But recently, usually the surgeons would like to implant electrode to do mapping out of intraoperative room.
Thank you. My third question is that frontal lobe is highly amenable for intraoperative seizures. So when you are doing an awake craniotomy for an eloquent cortex, how do you manage the intraoperative seizures that the patient could have? And this I'm addressing on behalf of various surgeons from the developing countries. They say that we do not have implantation techniques, but how safely can we do an awake craniotomy, and how do we manage if the patient has a seizure during surgery?
Your question, I'm not sure. I can't get your idea clearly.
Can I repeat the question?
Yeah.
So if you have a cortical dysplasia on an eloquent cortex and you plan to do an awake craniotomy and the patient has an intraoperative seizure, so how do you manage an intraoperative seizure?
Mm-hmm. So, Dr. Yu, do you have any idea about the intraoperative seizure? Do you have any experience during? So usually we can find the discharges from the EEG intraoperative in the intraoperative ometry. Do you have any experience about a seizure, real seizure during your operation?
Actually, only occurred in the during the process of waken up and to perform the cortical mapping. So we have to deepen the anesthesia.
Okay.
And yeah.
May I say?
So we use ice cold saline. So when we do awake craniotomy for epilepsy, it's not uncommon for us to find intraoperative seizures. So we generally flush the brain with ice cold saline, and with this, the seizure stops almost immediately. I just want to know your experience. Yes, Professor Ikeda, you were saying something?
Yes, I totally agree. My neurosurgeon is also doing exactly the same things. The ice cold saline is very effective for the immediate ceasing the seizures. So we always prepared.
Thank you. So I don't think we have any more questions. There is a question which has been addressed to Dr. Manjari, and maybe everybody could answer this. Are there any surgical options if the language area has not shifted? So the question is, you have a cortical dysplasia and the area is still positive for language. So how do you manage such a case?
So yes, there are options available, particularly in the West, in USA and equivalent countries where there is a responsive neurostimulation. So RNS placement over the eloquent cortex, that is one of the options available. Unfortunately, we do not have RNS in India, and I think even if we get it, it will be so expensive that it will be out of the, out of the reach of many people. So that's one option available in the developed world. The second option is to do a multiple subpile transaction, because that could to some extent be useful, but I do not know the efficacy of seizure control with that.
As a
last but not the least would be to do a VNS or a DBS, though outcomes with that would not be 100%.
I would be very hesitant to do a multiple subpile transactions, because we have had some experiences where the patient went into status following incomplete resection. So if you do a multiple subpile transaction, there will be a risk of throwing the patient into status post-operatively. So maybe other faculty can comment on this. So the question is, if the language is still positive for the cortical dysplasia on Broca's area, how would you manage that?
May I say?
Yes, Professor Ikeda.
Yes, that is the very the important question. We sometimes encounter in the past this kind of patient with a quite large cortical malformation covering the frontal to frontotemporal area. We decided to implant it subdural grid electrodes and then try to define that the seizure area by means of ictal DC shift analysis. We understand that in addition to that conventional ictal patterns, but the ictal DC shift can often delineate that the core area of the ictal area. So we could localize that the much more core area among that the conventional ICTA pattern. And then we could make that the functional, the cortical mapping directly by subdural electrode implantations. So unless that the patient have that the frequent violent seizure, that we decided to put that the coverage by subdural electrodes by means of cortical stimulation mapping as well as the ICTA DC shift mapping in addition to that the conventional ICTA patterns. That's what they try to do. But if it's all failed, we may do that the second surgery without resection. But so far we managed to define that the core core seizure area by means of ICTA DC shift. So fortunately, we have no cases where that we didn't make any resection in the second surgery. So that is our experiences.
So Dr. Yu, what would you do surgically?
If the lesion is not too large, sometimes we use the SEG electrode to do some radio frequency for this kind of patient.
That I think is a good option. Professor Wang, would you like to add anything before we wind up?
Yeah, I have no comment. So, as you know, the language area is widespread, not just as we image, just a very limited cortical area is related with language. So many spots, they integrated together functions during our language communication. So if you resect only very limited cortical area, very limited, let's say one spot or two, the language ability didn't get worse after the resection.
So we come to the end of this webinar. I would like to thank all the three faculty, starting with Manjari, Professor Yuping Wang, Professor Tao Yu, for having participated in this very important webinar. And before we close, on behalf of AOILE, I would request Professor Ikeda to say a few words.
Yes, thank you very much for that the great lecture and then the case discussion as always with the distinguished guest from China. So we all of us learned quite a lot. So probably the audience has understand that the epilepsy surgery is that they're very individualized. So that the opinion from each discussant is sometimes varied. But this kind of discussion is very important to reach to that some consensus with that the good solution of the patients. So we simulate that the cases for our the next future of our the next patients. So that this discussion will help us for all of us. So and again that they greatly appreciate for that all the effort for the staff and then the guest speakers. Thank you very much. You're mute, Sarah.
Thank you very much on behalf of the AOILE. Have a great weekend. Till we meet again for the next webinar of case by case, step by step. Thank you.